So we have an amazing trio of people here today with us for our NIPSI session. So I'll first introduce Andrea and Justin, and then Andrea is going to introduce her wonderful colleague Stefan. So Andrea is, I think, joining us for her first ever NIPSI session, but she is an amazing PhD researcher with expertise in pain and palliative care, who is at UCSF in the Division of Pediatric Pain, Palliative, and Integrative Medicine, and the STAD Center there for Pain, Palliative, and Integrative Medicine. And she has been involved with EPEC Pediatrics since 2010, and is currently serving as the co-I of their NIH NCI funded program. And she has many, many research interests around patients and their caregivers with serious illness, both in terms of like quality metrics and service delivery, but also kind of caring for children with palliative care needs and serious illnesses. So we're super excited to have Andrea. And I told Justin he doesn't really need much introduction, but Justin Baker is the current division chief at Stanford Children's, and has been there now. How long, Justin? 2 years?
Almost two, yeah, about 23 months,
Okay.
Just under 2 years. So
it has been there 2 years, and before that was the long-term division chief of pediatric palliative care at St. Jude, where many of us know him from, and never goes anywhere without a koala. Has published extensively in pediatric oncology and palliative care, and has given, I don't know, probably thousands of talks on palliative care that I think many of us have listened to and learned from over the years, and certainly shaped a lot of our careers. So that's the two of them, and I'll let Andrea do her introduction of Stefan.
Sounds great. Thank you, Catherine, and thanks for the warm welcome. I know you, like Justin, most know Stefan Friedrichsdorf, but it's my pleasure to introduce him today, along with Justin. He is a professor of pediatrics and the chief of pediatric pain, palliative, and integrative medicine at UCSF Benioff Children's Hospitals in the San Francisco Bay Area, and also directs the STAD Center for Pediatric Pain, Palliative, and Integrative Medicine. He is certified in hospice and palliative medicine, is fellowship trained and board certified in both the US and Germany. As most of you know, he is an internationally recognized clinician, educator, and researcher, widely published, and has given over 850 lectures in 30 countries. He leads the groundbreaking Comfort Promise initiative to prevent needle pain and anxiety in children. Has also founded the week-long Pediatric Pain Masterclass, which he founded in 2008, the only program of its kind, and has trained more than 1,200 clinicians from 67 countries through that program. In 2010, and relevant today to today's talk, he co-founded the Education in Palliative and End-of-Life Care Pediatrics, or EPEC Pediatrics program, with NIH and NCI support. Now, having trained over 2,100 clinicians across 122 countries. Together, we were recently awarded, as Catherine was saying, a second NCI grant to update its 24-module curriculum and expand training to rural clinicians. We're also hoping and expecting a grant for further expansion in Europe on the horizon, which I'm sure Stefan will talk about. So he's going to be presenting today about how to change clinicians' behavior and improve clinical care through EPEC Pediatrics, EPEC Pediatrics Curriculum Use and Dissemination Project. Welcome, Stefan.
Oops. Thank you very much. It is my pleasure to hand over to Justin, who's going to start heading us off. He's going to do the first half talking about the groovy EPEC Pediatrics program, and then I will do the second part and talk about how do we actually change clinician behavior, and those of you who stay until then, what opportunities you might have in joining us in this new grant. Justin.
Great. Thank you so much, Stefan and Andrea. It is an unbelievable privilege to get to share the stage with you all speaking about this. Catherine, can you give me a thumbs up if you can see that okay? This is Teams and we got it. All right, great. So, just as a quick aside, Stefan knows this, I said this in San Francisco just a couple weeks ago. The person in my iPhone that I have the most selfies with other than my family is Stefan, because we've had a chance to teach EPEC Pediatrics all over the world. It's been an incredible privilege, and actually even had Stefan invited him to St. Jude for his 50th birthday that he spent with us speaking about EPEC Pediatrics back in the day. So what a joy it is. I do have one disclosure. I wanted to make sure to say this. I actually finally worked on something and now do have a disclosure that I do get some money from US Pain Care. So NPC is so cool. I'm so proud of you all for establishing this. It's wonderful to be here with you all today. You know this better than anybody else does, and that is that education truly is the most powerful weapon which you can use to change the world. And you're going to see us kind of relate to some of the techniques we're going to use in EPEC Pediatrics. This is a hook. This is a hook. This is also a hook. Look at what you can do and how you can truly change the world through something like Dr. Stefan has led us through in all these years, and Andrea has been leading us through, in truly changing the world through education. And this is our one thing. Our one thing is Stefan already labeled this. When done properly, if you use this approach, it will lead to behavior change. And Stefan is going to walk us through each of these things. But as you hear us already alluding to, we've talked about a hook. We've talked about a one thing. You're going to see us talk through all of these techniques. When we started back in 2010, 2011, we had nowhere near the intention and ideas and really kind of understanding of pedagogy that we do now. And at this point, we both are teaching beautifully about pediatric palliative care, but probably the part that we've revolutionized the most is teaching about how to teach palliative care. And so I'm excited, Stefan will share more about that, but this is really our one thing. And I want to introduce the mothership, and the mothership is EPEC, the Adult Education and Palliative End of Life Care. It really began as a Robert Wood Johnson Foundation grant. This was back in the mid to late 90s. It was at the American Medical Association. They've trained hundreds of thousands of healthcare professionals. And there have been offshoots. There's been EPEC Emergency Department, EPEC Oncology, and by far the best and most important is EPEC Pediatrics. We actually still have Josh Hauser, who's leading the main EPEC group. Josh Hauser is a part of our EPEC Pediatrics group and a part of our historical grants and current grants and projects going forward. It is an international curriculum. It is truly changing the world. We have been all over the place. Upcoming, we're heading into Brazil, to the Czech Republic. We've been interesting places in the Middle East, in sub-Saharan Africa. We're heading there soon. And really, it's been an amazing journey that started back in 2010. And if you think about kind of when that first grant came that Stefan was the PI on, so much has changed over the past 14 years, 15 years. And now we have an opportunity really with this new grant that I'll talk about briefly to really update all the modules as well. Interestingly, we've also gone through a pandemic together, all of us here on NPC and through EPEC Pediatrics. And we realized this is pretty complicated and that teaching has to change also. And we actually put on our first virtual EPEC Pediatrics in March of 2021. We've since done multiple virtual iterations, and I feel like we've gotten really quite good at teaching in the virtual space. And so we're excited to add that to our repertoire of tools that we share through EPEC Pediatrics. As Andrea alluded to, we've trained almost 2,400 clinicians across 126 countries. This training has likely gone significantly beyond this because you'll hear us talk about how we have actually trained trainers who then have gone forward and trained others as well. This is a listing of all the different places. I mean, look at the places that we've been: Buenos Aires, Montevideo. We've been in Australia, Kampala, Uganda. We were in Nazareth, Israel. We've been to Salzburg, Austria multiple times, Rome a lot of times, and all across the United States, Guangzhou, China. And when you look at the list, we've actually done 32 official events. And again, we'll share these slides so you can kind of see where we're at. We've also published extensively on EPEC Pediatrics. It's the most comprehensive and widely utilized curriculum of pediatric palliative care. We've talked about it in the context of its use and dissemination. We've written about it in the construct of a national impact in Canada, for instance. Many of our Canadians are here on this NPC call. Hello. We also talked about it as we've done a regional adaptation with the St. Jude team, and Dr. McNeil, who's on this call, was the first author on this publication. And then we just finished with our session number 32 here in the Bay Area. And it is so incredible to be in the Bay Area here with Stefan and Andrea and all of our teams that are working on this. And many of our team members have also been trained in EPIC Pediatrics pedagogy and as trainers. So it's really self-sustainable, but we have to give huge congrats and thank you to the UCSF team and to Dr. Andrea and Dr. Stefan, because it is their funding that really got all of this started. And it was originally not designed to train pediatric palliative care specialists, but it is designed to raise the bar. And it really is designed to promote best pediatric palliative care practices, originally by hematologist oncologists. It was actually an NCI grant, as Andrea alluded to at the beginning. But we recognize also that really other pediatric specialists, and now the entire pediatric palliative care specialty in and of itself, can and does benefit from using this curriculum. There's 3 levels of training. One is really the end user conference, and this is where we just go and deliver the content that is EPIC Pediatrics content and expect the end user to receive that content and go out and use what they've learned. Level 2 is what we just finished here in the Bay Area, where we are training trainers. We're going to be changing the terminology we use. So we're going to be calling these EPIC Pediatrics lecturers. And these will be specific people who are trained in the pedagogical use of EPIC Pediatrics. And then finally, if you take an extra day of training in what we call a professional development workshop, you can then become a senior lecturer. Historically speaking, this was called as part of EPIC as a whole. This is still called as part of EPIC as a whole, a master facilitator. For reasons that are fairly obvious to us, we are trying to change that to senior lecturer. So just to put this in a different way, the trainers and the lecturers, this train the trainer conferences, these are people who then can go out and train end users and deliver the content. And then if we do that professional development workshop I discussed, they can become senior lecturers. Senior lecturers are who actually train trainers and lecturers. And then finally, Stefan and Andrea are the principal investigators. I'm a part of the core leadership development team of EPIC Pediatrics as it currently stands. There are 24 modules. Again, we will provide this content to you. Interestingly, when we were looking at kind of where the gaps are, it really was clear that there was nowhere near enough advanced pain and symptom management content. And so half of the modules are on advanced pain and symptom management. And as we go forward, there will be further expansion of these modules. We'll talk about that. When we think about these modules as we give them to people, they really are used to be in what we call an accordion module. And you might get, for instance, in respiratory, if you come back up here, if you look at neuropathic pain management and adjuvant analgesia, number 14, you might get 75 slides for that particular session. We expect that to be delivered in much smaller content, and Dr. Stefan will talk a little bit about how we deliver those things. Finally, we teach 3 main teaching modalities, which are case study, interactive lecture, and role play. We also teach a lot about dyads and buzz groups, and then we're also starting to teach much more on virtual techniques. And so that is, I think, a really interesting thing that will be expanding as we move forward. And when people go through our EPIC Pediatrics, they end up with a teaching guide, they end up with our PowerPoint modules, and they end up with these trigger videos. And I just want to share one trigger video in the short term here, just so you can see the caliber of these trigger videos, and we'll be expanding the repertoire of these as well.
So you're saying that there's nothing you can...
We cannot stop the cancer from growing. We can do is find ways to help you feel as well as possible and control your pain, and help your parents do the most for you.
I think that's probably not sharing through the screen, so I'll skip over that. But
it did work.
You could hear
it did work. Oh, good.
Oh, it worked.
That's great. Great. I will. I'm sorry then. I will skip us forward just a little, and we'll get to that point right there.
What we can do is find ways to help you feel as well as possible and control your pain, and help your parents do the most for you. Is it okay if we talk about some plans we'd like to consider to help you do that, Adam?
I don't care.
All right, Adam. Rick and Natalie. As you know, Francis is our coordinator of palliative care, and together we have lots of resources that we can offer you.
What are we doing here? Are we stopping attacking Adam's cancer?
Dr. Watkins, we think that it's best right now that we talk about the options for keeping Adam comfortable.
What Francis means is that regardless of the medical possibilities we consider moving forward, Adam's condition is going to be helped best by ensuring that he's comfortable, that we control his pain, and that he's where he wants to be doing what he wants to do while we manage his pain and other symptoms.
Oh my God. Adam.
Would it be helpful, Rick, if we stepped out for a few minutes? I'll come back and bring your family some water. Okay?
Thank you.
I'll return with some water for you, okay?
And so you can picture how you would use something like this in a variety of ways, but these videos have been developed to help to be a hook if you want to use them in that way, as Dr. Stefan will talk about, but also you could see how in a case-based study you might use something like this as well. As I wrap up my session, I just want to again congratulate Andrea and Stefan on getting our next grant, which we are very excited. This is the study team, as you see here. Dr. Wolf and Stacy Remke and Dr. Hauser and I and Dr. Brown and Nick Perul and Dr. McCarthy are all investigators on this particular study where we think about phase 2, where we're looking at disseminating EPEC Pediatrics in geographically diverse U.S. areas, and we're updating and expanding the EPEC Pediatrics curriculum. Your next chance for you to sign up, which I'm sure Dr. Stefan will also talk to us about, is in Albuquerque over March the 24th through the 27th. And we'll be heading there as an EPIC Pediatrics team. So as we close, I return to our one thing. What we have found is that when we properly deliver this curriculum in the EPIC Pediatrics pedagogical manner, we've really noticed and we've seen how we can truly change the world, and that this approach really has led to significant behavior change. And so with that, I'll stop sharing and turn things over to Stefan, and just want to once again thank him and thank Andrea for the unbelievable opportunity to be a part of this. And want to thank you, NIPSI, for letting us present on EPIC Pediatrics.
Thank you. Thank you so much, Justin, for this great overview of EPIC Pediatrics. And I think, I wonder how many of you are already trained in this. Let us know in the chat. We can sort of have a look, and maybe we see some of you in the future. So welcome. Here from San Francisco. I'm on service this week, and I'm happy to chat to you. So let's talk a little bit about attitude, knowledge, skill. How are we teaching through an interactive lecture? So my objectives are really to quickly, as Justin has said, talk a little bit about our new grant and how you might be get interested in that. And then the content of this particular lecture is like, how do we teach and we change behavior of our audience and not sort of making them fall asleep? So we're going to talk about, as Justin already did on the one thing, the hook. We're going to talk about how do we address attitudes, myths, barriers, obstacles, talk about knowledge and skill, and then talk about different presentation modalities, which would be effective for us as pediatric palliative care educators in teaching, in training, and in changing the world. So as you heard, we just in end of July received a $1.6 million grant from the NIH, from the National Cancer Institute, for round 2 of EPIC Pediatrics. And so we want, one thing is that over the next 5 years, we're going to show up in areas which are slightly away from the main centers. So we're going to start with Albuquerque. We're currently discussing whether we do Jackson, Mississippi, or maybe Birmingham, Alabama, sort of for 2027, and the other 3 places are not decided yet, so we can talk, so stay tuned for that. And then we of course want to update all our modules. Many of them were done between 2010 to 2012, and while we constantly update this we now want to really make sure that we have the latest and best sort of research data and information of 2025 in them. And so we will have a guidance from interprofessional group of clinical experts, which help us to do that. We are particularly proud that we will be able to create a psychosocial spiritual curriculum, so something for non-providers, so because originally the original EPEC Pediatrics was designed for people who are prescribing medications, so mostly physicians, nurse practitioners, physician assistants, and so on. And while we always made sure that it was relevant for social workers, psychologists, and nurses, and so on, we are now going to put a much bigger strength on this, and we're very excited about that. So what is the opportunity? You should within the next week or two actually hear about the usual channel, the usual propaganda channels we have in our field of pediatric palliative care, that we will put out an RFA. So we are looking for 10 additional clinicians. We already have had identified 11 who will join our interprofessional psychosocial spiritual oncology and palliative care expert team. So basically the advisory board for the next 5 years. And in order to do so, you either are already an EPEC Pediatrics trainer or you're interested to become one. So you would actually then go through our training either in Albuquerque or in Mississippi, then go through as Justin went, the 3 stages, went through the professional development workshop, which is an advanced training to become an educator, and then would actually teach with feedback from what we used to call master facilitators. We now changed the name to senior lecturers. So you will have senior lectural background. So if you're interested, watch out for this. You can already be proactive. Just send us an email, epec.pediatrics@ucsf.edu. For any contacts, epec.pediatrics@ucsf.edu. And once Andrea and I are ready to send it out in a week or two, we can then send you the invitation. All right, let's go to teaching. Some of you, many of you, all of you may have been part of an ineffective medical lecture you attended. What went wrong? All right. Catherine, can you tell me what's happening in the chat? What are people saying?
Yeah, people were saying there's no interaction. People are just being talked at. Too many slides in a short amount of time. Death by PowerPoint. The slides are too wordy and confusing. They don't seem relevant to the audience. And there's minimal kind of real life examples or storytelling.
Thank you. So, in other words, we tend to play bad presenter bingo, right? So this is, and you can see how who's going to get 5 in a row of thinking of a particularly bad one. I know the slide is a little busy. Yeah. Face the screen, laptop, not you. Font smaller than 20 points. Copy and pasting tables right straight from the article. Yeah, apologizes for presentation, runs over assigned time. Okay, I hope I'm not doing this. So there's no time in the Q&A, yeah. And my absolute favorite is, of course, that skips through the second half of the slides in the interest of time. Yeah. So let's do that. I'm not doing this. So EPEC Pediatrics, and I think all of you who are doing this professionally know that slides are a tool, and they are quite helpful in some situations, but we can equally teach better or even without by using role play or cases in this case. But still, PowerPoints, or I'm an Apple user, keynotes, of course, are very, very effective. And but there are a few minor details to look at.
There's some things I hate about PowerPoint, and I figure it's kind of my duty to point them out. So here we go. Here's common PowerPoint mistakes. Number 1, people tend to put every word they are going to say on their PowerPoint slides. Although this eliminates the need to memorize your talk, ultimately this makes your slides crowded, wordy, and boring. You will lose your audience's attention before you even reach the bottom of your first slide. Please don't do that anymore, please. Number 2, most common, many people do not run spell check. Big mistake. Nothing makes you look stupider than spelling errors. If it's got a red line under it, recheck the spelling. And finally, I hate this. Avoid excessive bullet pointing, only key points. Too many bullet points, and your key messages will not stand out. In fact, the term bullet point comes from people firing guns at annoying presenters. Hence the bullet point. Bad color schemes, not good. Clashing background and font colors can lead to distraction, confusion, headache, nausea, vomiting, and loss of bladder control. I can't stay on that one too long. Here's something I've noticed. The number of PowerPoint slides you have in your talk, the less useful your talk actually is. Unfortunately, my presentation is right there. I've also noticed this. People love to pack data into their presentations. They just shove more and more data thinking it's better, but it's not. The more data you have, the harder it is to read your slide, and the effectiveness plummets. Now you can improve the effectiveness by adding some shading and some 3D effects, and then some second order and third order effects, and then, I know, let's add some labels. That'll help a lot. And that's pretty much every marketing slide I've ever seen right there. Yeah.
Point is, most of the time, many times when we go somewhere, the idea is that the speaker's there and just is under the misconception, I just have to provide so much knowledge, then I'm clearly going to change the behavior of the participants. And everyone who has been being an educator in pediatric palliative care for more than 10 seconds knows that nothing is further from the truth. That in fact, people take out their phones, right, because it's a useless presentation. They work on their emails, right, and then at the very end look up and at the conclusion slide say, okay, what did I miss? Nothing, right? So this is basically something. So how do we make this better? How? And that's what EPEC Pediatrics is about, teaching how to teach how to teach. How can we enable clinicians all over the world to give an educational lecture, an interactive lecture, and hopefully change the behavior of the audience today or tomorrow or next week, for that matter. So this is, I put everything in there, right? Here it is. You can just quickly read this. This is how we do it. Right? This is what I'm talking about. This is a useless, terrible example of like putting crap on a slide, yeah, and like reading it, and it does not change any behavior. It will not make you a better teacher or better educator tomorrow in looking through all that. So Dixon in the 1970s already thought, like, if you have a hook, an emotional content, if you address barriers, myths, attitudes, provide the knowledge piece. We already are good at this, but make less of this, and then really spend some time on skills, then you have a 10 times higher chance of having a behavior change in your audience, in your participants, for that matter. And those behavior changes then actually improve patient and family outcome. In other words, if we want to improve the quality of life of kids with serious illness, just providing the knowledge will not do this. We have to go through the steps. So this is our cheat sheet you get when you're, those of you who participate in palliative in EPEC Pediatrics are aware of this, right? And every time you create a lecture, a grand round, something for residents, that's what you go through. And you're going to increase the chances of behavior changes to 10 to 100 times. And then after you've practiced, that's where you're going with. All right. The one thing is, what is the one thing? What is the one behavior you want your audience to do differently? Is the one behavior, I want people to be comfortable to give morphine to an infant at end of life? If that's the fact, right, then this is what the lecture is about. This is what you want to do. People tomorrow should be fine with doing this. It's the one thing you actually want people to put in a palliative care consult. Yeah. So if that's the one thing, this is what your lecture is about. People often tend to put too much things in there, but really think about what is the one behavior I want to change, and then everything else flows from that. Yeah. So and this one thing is something you talk about at the beginning. Then you provide the knowledge and pieces in the middle, and then talk about at the end. Yeah, so that is basically, it's an introduction, and there's a body, and there's a summary. So I'm going to give you an example of how I use our module 13, which is procedural pain management. And my one thing is always offer numbing cream for needle procedures, always. That's my one thing. So starting with a hook, as I said about. So I'm now going into actually teaching the actual lectures. I will use about 10 minutes or so, or 12, of giving like part of the lecture I would sort of give. And then in between, I sort of go forth and back. We can discuss it a little. All right. So if I see many of you here from the United States and Canada, if I would spend the next 24 hours in front of your institution and I ask every single child, what are you most afraid of seeing the clinician right now? What is the answer? Yes, it is needles. Kids are really, 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 really afraid of needles. And the parents are too. Because when they come to us, this is what they get. Even healthy children undergo 16 to 18 vaccinations in the first 2 years of life, hopefully. But once they get sick, then of course they have blood draws or lumbar punctures or stitches or injections or IV cannulations, which causes a significant amount of pain and anxiety. So using module 13, our EPEC pediatric procedure pain management strategy, let me show you a short video. So this is Marius. Marius is a 5-year-old boy who fell off the bike on the beautiful island of Bornholm in Denmark. So this is actually in Danish for the next 60 seconds. Is anyone not fluent in Danish? Anyone? Yeah, so, oh, I see 1 or 2 of you. Okay, so even if you do not understand Danish for the next 60 seconds, this starts out really, really well. He's very compliant, fantastic nurse, he's getting stickers, and then something is going wrong. So in 60 seconds, I wonder if you could put in the chat, what is going wrong here?
Du slår din finger, sæt du ham op her. Han har fået revet det yderste stykke af fingeren af, og det hænger meget løst. Hvad var der sket? Lidt. Nu pakker jeg den op forsigtigt her. Så kommer mit i, kommer til skade. Og pakker fingeren ud af forbindingen, kan jeg se, at det er det vi gør, når vi skal bedøve fingeren, sådan så at det ikke kommer til at gøre ondt, når vi skal rense og sy. Og berolige drengen hele. Vi holder hånden der. Så en 5-årig dreng kan godt være rigtig stærk, så vi er nødt til at hente noget forstærkning, som simpelthen kan holde ham fast. Både at bedøve fingeren, og vi er ikke nogle flere kollegaer, og så er vi 5 voksne mennesker, der er nødt til at holde hans lille arm, for at vi kan få det.
Well, should we quickly count how many adults are holding down this 5-year-old boy for an elective procedure? We're not saving lives here. This is unethical. This is bad medicine. And there's no excuse that we're doing it, yet it can happen in any of our institutions, most likely tonight. And often when I teach, I hear something like, yeah, Stefan, yeah, I hear you, but we just do not have enough staff for pediatric pain control. It's amazing. We always tend to have enough staff to hold down children. All right. What was my hook? A hook is sort of the idea that I have a tension point, build some sort of like emotional contact with you. Yeah. So if you can put in the chat, and Catherine, if you could read to me, like, what do people saw here as my hook?
The child himself is a hook in a way. Video,
child himself, correct.
To me, it was like the internal feeling I had watching him being held down of like, this is awful, like it created an emotion in me.
And that exactly, Catherine, and everyone, that is the idea, right? So basically say, oh my God, yes, we're doing this. How can we do this better? And we're thinking about ourselves or our own kids or something like this. So that is the way to do the hook. And right, we have in EPEC Pediatrics, there are hundreds, not true, like many dozens of those trigger videos, and you can just use your own things. You can use a case, right? Something which is in there, something which basically, okay, people are likely to put their phone down and actually are going to listen to the end and like, okay, how do we do this better?
Estee also said the black slide with your question about what child fear was a good hook for her.
Thank you. All right, so I talked about the one thing, which I'm going to come up in a second again. We had our hook. The next thing is basically, it's why people are not doing what I want them to do. If I have the one thing, I want people to put numbing cream on, why are they not doing it? So in my lecture, I would talk about that best evidence is, best medicine is, the best ethical approach is that we should, in our institutions, for every child, every time offer numbing cream, Emla, lidocaine cream, amikine cream, something like this. We should always offer sucrose or breastfeeding for babies younger than 12 months old. We should never, ever hold them down. And we use some age-appropriate distraction. And we're going to talk at the end about giving choices and also reframing the memory. So why is this not happening? So if I basically tell you, okay, from tomorrow on, this is going to happen to every child in your institution for the rest of your career, what would you hear from your colleagues or from parents why this may not happen? So if you can go to use this QR code with your phone, or you can just go to menti.com and put in the code 4994-8910, and you can put in more than one things. What will you hear from your colleagues why this cannot happen to every child every time, as opposed to some children some of the time in your institution tomorrow? No tengo tiempo. Time. Costly. Takes too much time. Yeah, so personnel. Not having the staff. Yeah, I will miss the vein. Oh, no child life. Doesn't work. All right. So there seem to be among your colleagues, wink, wink, lots of thoughts about why this cannot happen. It's just a small poke, right? Doesn't work. Personnel and all that matter. All right. So in order to change behavior, I want to find out why is my audience not doing this? So looking for, we call this attitude, what it means, like what are the barriers? What are the obstacles? What are the myths? And then in your next piece, in the knowledge piece, you want to address exactly those thoughts. Because when I say, why would your colleagues not do it? It's a much safer way of asking, why would you maybe think about this? And it might truly be your colleagues, or it may actually be that your audience is thinking this, but then it's easier to admit this. And then the things you said, like there was a lot about time, there was about missing the veins. So these are the things I must, as in have to, as there's no other bloody way, address in my knowledge piece and counteract them in order to allow people then to change their behavior. And then we come to the knowledge piece. The knowledge piece is everyone here has been doing this for 10,000 years really, really well, right? So this is sort of you present your knowledge. And the idea is basically, I have 75 slides to discuss in 10 minutes. Save your question to the end. Sit down and never talk to me again as long as you live. How did the CSO presentation go? It was 70 slides, too long. So let's go into the knowledge piece. So why bother? There was one person was what I was saying, it's just one poke. Well, turns out that it's not just one poke. Kids are afraid hours before. They may be hours behind. And kids who are in persistent pain suffer more physical symptoms in adult life. So these are kids, these are adults who become more likely to become needle phobic, have more anxiety, have more depression. And if we do something unethical, if we do something bad, as we've done with Marius here, holding him down for an elective procedure, this child will require more analgesia and more anesthesia in subsequent procedures. So those kids who stop the healthcare system, where we need suddenly 5 adults who are screaming outside your hospital or your institution in the car, that's our fault. We caused that because we held them down in the first place. 1 out of 4 adults have fear of needles, which is mostly then developed in childhood. And this has long-term consequences: anxiety before and after procedures, more pain, needle fears, and avoidance of healthcare. A large number of people who do not get vaccinated, who tell us, well, I did my own research, I found that you just have to stay really healthy or use vitamins, they're afraid of needles. Of course you have anti-vaxxers out there, that's a different thing, but the vast majority, they're afraid of needles. And I personally have taken care of 5 children who died of measles. So this is something which clearly, especially with the current political system here in the United States, something we have to address quite vehemently. So how then do we eliminate or at least reduce pain and anxiety caused by needles? So I asked one of the most famous American philosophers, Joe Tribbiani, and he said it's not rocket surgery. All the data, of course, has been on for a long time. So we created at Children's Minnesota the first comfort promise for every child, every time. This now has been rolled out in over 35 children's hospitals all over the world, and in Denmark, in Canada, in the United States, and then with the support from Mike McNeil, who's on here, now in many countries in South America, in Southeast Asia, and in Africa. So number 1, of course, is numbing cream. Numbing cream is the single most important thing. And when we do this, Dr. Cox, I'm really worried about cost and increased staff for work. Can't we just skip this lidocaine cream thing and for needle pokes and just use like a cheap and easy approach?
Good God in heaven, there are just so very many ways for me to say this to you. Never, not in a million years, absolutely not. No way, Jose, no chance, Lance, yet, negatory, nah, and of course my own personal favorite of all time, man falling off of a cliff. No! Dr. Potts.
So can numbing cream be substituted? Is it ethical not to offer numbing cream? And teenagers may say, it's fine, go ahead without it. That's cool. Yeah, teenagers may opt out. No baby is going to opt out. So, because since there is significant, when you start to implement a comfort promise, there will be significant staff resistance against the use of EMLA cream or numbing cream. The rather like the priority has my workflow as opposed to what's right for the patient. And so can it be substituted? Can we use something else instead? And the short answer is no. The long answer is, other than J-tip, still no. We found that numbing cream by far has the best effect of taking pain away. Among 1,226 children in Latin America and 4 Latin American countries, topical anesthesia was actually the most effective modality of the bundle with an odds ratio of 9. Kids were 9 times more likely to say, I have no pain with the needle poke. Those were kids with cancer. Than not having the numbing cream. All the other stuff worked as well, but it was like 2 times the odds ratio were 2. So it's a good addition to that as well. And we have other data showing, which is still under revision, showing that a significant increase. Again, this is something Mike McNeil will be first author on. Can we use something else? Yeah, so there's single studies, and this is usually industry sponsored, which basically use like an unethical approach. So you basically have half the kids get nothing, and the other half get like you knew one thing, right? And you found that like the cool spray, for instance, that in adults, if you compare to nothing, it reduces the pain like only on a 0 to 10 scale. In kids, it doesn't. Yeah, it is not effective, and children actually do report that the cooling spray hurts. So again, not working, can be not recommended. What about a vibrating cooling device? The Buzzy device is not as effective as numbing cream. So, so we currently do not have enough evidence for or against shot blockers or Buzzy bees or other things. So point is, you can use them in addition to numbing cream, not instead of numbing cream. And no, the numbing cream does not constrict the veins. That was another thing we heard from some of your colleagues. In fact, it might even be slightly easier. So vein constriction was a myth. Other things, and I will only briefly talk about this, of course, are breastfeeding or sugar waters for babies younger than 12 months. Comfort positioning, we will not hold children down, although this is a very poor position for drawing some blood. So Charlotte, for painful procedures, isn't it just the best to hold you down and do it quick? Charlotte seems to be very, very clear that she does not want to be held down. And I want to be very clear that those bloody papoose boards, which you still can buy in 2025 on Amazon for $1,025, that is not pediatric analgesia. In fact, if you ask children, what is it like to be held down for painful procedures, they tell us that they feel ashamed, humiliated. They tell us that they've lost their right to control their own life, their own body. So parents' job is not to hold down the child. They can comfortably cuddle their kid and of course make sure that the arm is not flailing, but that's about it. For babies, we may do swaddling or facilitate tucking, kangaroo care. We use age-appropriate distraction. We give some choices. Do you want numbing cream left or right? We do some memory shaping. We use some sentences so that they remember those things better. All of that is something which is sort of in the bundle for the comfort promise. Bottom line is failure to implement evidence-based pain prevention and treatment for children in medical facilities is now considered inadmissible and poor standard of care. All right, so that was my knowledge piece. And since I have to do it much, much shorter because there's other things around, I put more stuff in my slides. There will be links for the matters for more audience. The next piece is to really remind everyone is that, of course, an interactive lecture can be a very important tool. Much better things would be role play. So at EPEC Pediatrics, we spend a lot of time the same way as I went through detail right now, how we teach, how to teach. Well, through an interactive lecture, how to actually do a good role play, something which is not traumatic, which is not basically traumatizes everyone in the audience for the rest of their life, and is sort of completely pointless, into something we use that as a tool to really use certain words, languages, sentences, and make sure that people feel safe and comfortable. And how would you use case examples very successfully? In terms of a skill, we want to make sure that at the end of our presentation right now, people have a chance to sort of deepen their skill. So think of your very next pediatric palliative care lecture. What is the one thing for your next educational system session? If you could put this in the chat, and then Catherine, Naomi, if you can read it to me. Yeah, what is sort of your one thing for your next pediatric palliative care educational session? What is the one thing you want your audience to do differently after that lecture?
I'll say I'm giving a lecture on Thursday, and I want people to take away that being honest doesn't mean taking away people's hope to a group of oncologists.
That's a great one thing, right? Yeah, so that if that's the one thing getting out of there, then it's a great lecture. Fantastic. Any other?
Justin said that measuring appropriate outcomes matter.
How good.
I know many of you have lectures probably coming up and things that you're teaching about.
Next week, we'll be doing a workshop in Botswana with a bunch of leaders in pediatric palliative care, and we'll be helping them craft their elevator pitch to advocate for pediatric palliative care at their institutions and on a national level. And so ours will be over and over again, craft your pitch again and again and again, and you practice it again and again and again.
Fabulous. So think about your one thing, and always leave enough time for skill at the very end. If you want people to be not afraid of prescribing morphine to a baby at end of life, well, let's do the math. Then you put up a skill. This baby weighs 4 kilograms. What is a normal morphine starting dose? So that people actually have to take their calculator, they do the math, they write the dose. If people have to do the math, they're 10 times more likely to do this rather than you showing it or sort of giving them starting doses on a slide. And then, of course, after you've done all of this, you practice, record yourself, yeah. And because if you just click, we give you lots of PowerPoints as an EPEC pediatric trainer. And Fluffy, will clicking through my EPEC pediatrics PowerPoint slides improve pain and symptom management for children with serious illness? It does not. All right. I hope I can convince you that designing a lecture is that you think about what is your one thing, think about your hook. And then when you write your objectives, what's the attitude, the barrier, the myth? That's your objective 1. What is the knowledge piece? That's objective 2. And what's the skill you're going to teach? That's objective 3. And then, of course, making sure that you used interactive lecture for the right audience, and make it interactive, hence the name, practice. And then any feedback is love, improves any skills. We talked about Pain Masterclass. If you're interested, do see us here in January 2026. And then we have more EPEC Pediatrics conferences coming up. All right, any questions, comments at the last 23 seconds we have?
I had a question for you and Andrea about, as you guys have been doing this curriculum now for many years, and are constantly improving and coming up with new iterations of things and going to look at revamping the curriculum. What are sort of the interactive strategies you've used over time to engage the audience that you feel like have not worked and you're kind of getting rid of over time versus like what you feel like really works and are trying to lean in, more to?
That's such an excellent question. I think it is hard to answer because it depends on your style. So I think what we want to mirror at EPEC Pediatrics is that all of us have very different styles. So both Justin and I are more on the, you will be surprised to hear this, yeah, take a moment, that's fine. We're slightly more on the extrovert side, right? And that is something, yeah, he and I are very comfortable with, right? And but other people might be much more introverted, not very happy to show cat videos. So I don't think I actually ever thought of getting rid of anything. I think what we're finding is find your own personal style. What is sort of working for you as a teacher, for an educator. We still work sort of through the system. And I think over the years, we have noticed that people really have a lot of trouble when we explain how to address an attitude. Yeah, so that always is a big thing. Like, how do we actually find out what barriers or obstacles or myths is and then to address them? People have trouble like leaving enough time for a skill, and because the comfort zone is the knowledge, right? The comfort zone is like putting lots of slides together and somehow fantasizing that then people do something different tomorrow by just giving lots of slides and sort of not doing this. Is that a vague enough answer?
Yeah, no, it's tough. I mean, I think we all like sort of are trying to improve our teaching and use the right skills and get rid of the ones that aren't serving us. And yeah, and it's hard. And sometimes you're adjusting year after year in your curriculum. And sometimes you're even like trying to think, do I need to adjust on the fly in this session because what I'm doing isn't working, And
I think, is like the better an educator you are, the more you're comfortable doing this, right? So if you're completely flipping out of, oh my God, this is totally not working, right? Then do a buzz group, right? You pose a question, then talk to your neighbor about the following thing, right? That gives you time to sort of rearrange your slides or sort of going around or not very, very wisely as we sort of doing the buzz group, right? Sort of what's working. And if you do a needs assessment is another hook, right? Why am I here? What are you guys hoping for? So we have the next year, you have a bunch of learners in the audience, right? We have the next 30 minutes together. What do you hope we are talking about before I leave this room? Yeah, and you sort of write this down. That may completely change what you're sort of planning and make it more relevant again.
Yeah, it's almost like how you would open a family like conference or family care conference, right? What to the parent, what are you hoping to get out of this, get out of this meeting, right? And Kelly, I see your hand up too. And then we'll end after this last question.
Thank you so much. That was absolutely amazing. I was wondering how you like to follow up. So after your lecture or after the training, how do you like to ensure from like a measurement standpoint, which I think is a really hard question to get at and probably answer, but how do you like to do like a follow-up to be like, hey, the skills are staying with that person. They took this away and they're continuing to do that. if that's one of the things, or if you do another lecture in a couple of months to follow up, what is things that you have found have been helpful to ensure that the skill stays?
I think it very much depends on what you're doing and who are you seeing, right? So you can, if you teach something and you have the emails of the audience, right? You can ask a survey, right? And you basically, like, whatever it sort of is, like a month later, 6 months later, sort of, what improvements have you seen? Give examples, right? You can do something very open. So if you have the man or woman power to follow up with that, yeah, that's one way sort of to do this. If it's within your own institution, you can do some audits. Yeah. So so what has the morphine dose been, right? So like, how many consults did we get from that particular unit? So you probably want to be creative and not create too much work, but having something meaningful. Does it answer your question?
Yes, thank you so much. I appreciate that feedback, especially from like the needs assessment or the audits, to kind of see how everyone is doing after the lecture. Thank you.
Well, we're so grateful to have you guys here today to talk about the EPEC Peds curriculum, but also to talk about how you teach that with your hook assessment knowledge. And now I'm blanking on the S, of course, because it's, the end of the day, skills, and the one thing. And I think it's really important. That's the whole goal of NIPSI as well, to think not only just about the content, but about how we teach. And so we really appreciate you guys being here today, and feel like EPEC Peds really nicely dovetails with the mission of NIPSI. Our next session will be in December on publishing your academic work and how to get past that reviewer number 2. And we'll have a couple of different people who are on editorial boards and really are on the receiving end of the journals that we submit. And so we'll be our session in mid-December. So you'll see an invite to come out for that as well. But we hope you all have a good rest of your day, and thank you so much for coming. And if your colleagues want to watch this session, it will be up on our YouTube channel at some point. Bye, guys.
Thank you. Bye.
Thanks, Stefan. Thanks, Andrea.
Bye.
Thank you. Bye-bye.